Hello. My name is Dr. François Ricard. I am an osteopath and a PhD. I am director of the International Madrid School of Osteopathy, EOM, and president of the Scientific European Federation of Osteopaths, SCFO. In this video, I want to talk to you about the effects of spinal manipulation in case of neurological sensitization. Part 2. What can be the osteopathic treatment? According to Wright, 1995, the effects of manipulations are mediated by endogenous pain control systems, and are given by descending inhibitory mechanisms of pain, from upper centers as opposed to the nociceptive inhibition mechanism, through afferent neurons at the spinal level. The application of manipulative therapy has immediate hypogesic effects, observed in a period of seconds to minutes in patients. This is associated with an immediate sympathetic excitatory period, that can be demonstrated by changes in central and peripheral indicators, in the activity of the sympathetic nervous system. Osteopathic treatments, particularly HVT, have several reflexogenic effects that inhibit pain. Melzack-and-Wall's gait control theory, 1965, outlines the active role that the dorsal horn of the spinal cord plays. The dorsal horn is not simply a point of passive transmission for sensory information, but is also able to modulate pain signals. Besson and Chouch, 1987, note that several studies, inspired by Melzack-and-Wall's theory, have clearly shown that non-noxious mechanical inputs that travel along the A-fiber neurons can inhibit the response of the neurons in the dorsal horn to C-fiber noxious stimuli. For Picard, 2002, one mechanism underlying the effects of spinal manipulation may be the elimination of subthreshold stimuli produced by changes in joint movement, or joint play. Furthermore, non-noxious chemical impulses can also have a therapeutic effect. Besson and Chouch, 1987, have shown that the activation of three fibers A-alpha and A-beta reduce chronic pain and increase pain threshold. Melzack-and-Wall's control mechanism contributes to the effects of a spinal manipulation, and has a long-term effect. Non-pharmaceutical interventions restore proper signaling within the hypothalamic pituitary adrenal axis, and between higher structures. Exercise increases dendritic complexity, and brain-derived neurotrophic factor expression in the hippocampus, which restores negative input onto the hypothalamus to restore proper hypothalamic pituitary adrenal axis output. 1. Decreased corticotropin-releasing factor release stabilizes mast cells activation and infiltration associated with chronic pain disorders. 2. Thereby reducing peripheral nociceptive input. Exercise influences the descending pain pathway, likely through release of endogenous opioids, increasing neuronal activity, and balancing excitatory and inhibitory transmission. 3. Cognitive behavioral therapy alters the intrinsic functional connectivity between brain regions associated with pain management, including connections between the prefrontal cortex and amygdala, and somatosensory cortex, and the basal ganglia network. 4. Cortical and hippocampal gray matter densities are also increased in patients following cognitive behavioral therapy. 5. According to Schender et al., 2012 and 2013, osteopathic manipulation reduces sympathetic activity, as well as the release of cytokines, creating a cascade of biological and neurological events that modulate inflammatory mechanisms and the autonomic nervous system. The study by Katovich, 1998, showed that spinal manipulations reduce central sensitization and the excitability of the alpha motor neurons, as well as aberrations of movement. Sensory afferents produced by the spinal manipulation could stimulate neurophysiological pathways to inhibit pain and muscle responses in instances of acute nociceptive pain. Henley et al., 2008, Giles et al., 2013, and Ruffini et al., 2015, showed that osteopathic treatment affects the autonomic nervous system, producing a parasympathetic effect, and therefore inducing a state of trophotropic tuning. According to Vyuk, 2006, it is important to pay attention to and report any spontaneous sensations described by the patient during the treatment phase, as this can produce potential homeostatic and allostatic feedback, which can be used to optimize treatment. According to D'Alessandro et al., 2016, several therapies, including osteopathic manipulative treatment, could be theoretically administered to solve neurological sensitization in different clinical conditions, where peripheral and/or central sensitization are present. For Ursin, 2014, it is important to consider the patient's emotional and psychological state during treatment, any anxiety or fear, as this will affect the patient's perceptions. According to Warkowski et al., 2014, osteopathic treatment can produce a biological and neurological cascade of events that change the interoceptive processes, breaking the vicious cycle of an ongoing low-threshold inflammatory condition. Peterson et al., 2015, showed that osteopathy can change a sensitization state at all levels, using interoceptive pathways. According to Gay et al., 2013, pain sensitivity may serve as an intermediate physiologic endpoint, helping to establish optimal manual therapy treatment parameters. According to Bishop et al., 2015, manual therapy is applied directly or indirectly targets to a variety of anatomical structures or systems, which is utilized to create beneficial changes in the patient pain experience. Manual therapy is grounded on clinical reasoning to enhance patient management for musculoskeletal pain by influencing factors from a multidimensional perspective that have potential to positively impact clinical outcomes. The influence of biomechanical, neurophysiological, psychological, and non-specific patient factors, as treatment mediators and/or moderators, provides additional information related to the process and potential mechanisms by which manual therapy may be effective. According to Bishop et al., 2015, moderators and mediators of the pain experience resulting from manual therapy interventions according to top-down moderators. They include habituation, graded exposure to mechanical stimuli, sensory discrimination training, cognitions, expectations, placebo or meaning response, contextual factors, therapist effect. Central mediators: changes in spinal excitability, changes in motor function, decrease in cortical excitability, decreased activation in brain pain processing areas, decreased activation of facilitatory/increase in inhibitory pathways, changes in resting state brain functional connectivity. Peripheral mediators: biomechanical, increase ROM, decrease passive stiffness and active stiffness. Neurophysiological, changes the concentration of inflammatory and pain mediator substances. According to Coronado et al., 2012, Spinal manipulation is commonly used for treating individuals experiencing musculoskeletal pain. Immediate effect of spinal manipulation on mechanical pressure pain threshold. Spinal manipulation demonstrated a favorable effect over other interventions on increasing pressure pain threshold. Subgroup analysis showed a significant effect of spinal manipulation on increasing pressure pain threshold at the remote sites of stimulus application, supporting a potential central nervous system mechanism. According to Meltzer and Stanley, 2007, Licciardone et al., 2012 and 2013, osteopathic touch is supposed to produce an anti-inflammatory effect, and, according to Ruffini et al., 2015, a hyperparasympathetic effect, potentially modulating vegetative firing. It can produce positive feedback effects on the sensitization state. According to Kuchera, 2005, osteopathic manipulative treatment, OMT, is a physician-directed approach to patient care that incorporates diagnostic and therapeutic strategies to address body unity issues, enhance homeostatic mechanisms, and maximize structure-function interrelationships. Osteopaths integrate a thorough medical history, with palpatory examination of a patient, to ascertain distinctive characteristics and origins of the patient's pain, to evaluate how pain uniquely affects the patient, and to determine whether segmental, reflex, or triggered pain phenomena coexist in the patient. Osteopathic manipulative medicine expands differential diagnoses by allowing to consider somatic dysfunction and implement treatment options via integration of specific aspects of complementary care into state-of-the-art pain management practices. Prescriptions formulated through an OMT algorithm integrate each osteopathic tenet with biopsychosocial and patient education models, as well as manual medicine, pharmacologic, and rehabilitation techniques, proportionate to individual needs. Here, we can see a sample for osteopathic manipulative treatment, OMT, protocols for enhancing homeostatic responses according to Kuchera, 2007. The treatment protocol includes 4 basic parts. Expansion of biopsychosocial model includes touch stress reduction, basilar decompression and CV4. Sympathetic model includes collateral ganglion inhibition, paraspinal inhibition, thoracolumbar and costal OMT, rib raising technique, soft tissue techniques. Respiratory and circulatory, venous lymphatic, model includes open fascial pathways at transition zones, redum thoraco-abdominal diaphragms, lymphatic cavernous pumps, mobilize peripheral edema. Parasympathetic model includes cranial nerve 3, in the on-balance technique, sphenobacillus synchondrosis technique. Cranial nerve 7, sphenopalatine ganglion OMT. Cranial nerves 9 and 10, occiput atlas, atlas axis, occipitomastoid suture. Pelvic splanchnic nerves, sacroiliac joint. Diagnostic and treatment approaches for chronic pain. Pain question flow chart. According to Nace et al., 2015 and 2016, and Fryer, 2017. In case of central sensitization, the OMT must emphasize on biological mechanisms and on psychosocial mechanism. Aims of management include reassurance, reduce fear and anxiety. Address inappropriate beliefs and behaviors. Pain education. Promote confidence in movement. Encourage increased activity. Plus, Some manual therapy addressing biological factors. Decrease pain. Promote mobility and flexibility. Improve sensory motor integration and motor control. Exercise prescription. One, immediate analgesic effect according to Melzack and Walgate control theory, 1965, plus endorphin-releasing action. From the sinew vertebral nerve. Two types of nerve fibers start from the joint capsule that reach the posterior horn of the spinal cord. Thick diameter fibers that convey information on joint position and movement. Small diameter fibers that convey painful information. During manipulation, a massive stimulation of the large diameter fibers occurs, because the joint is opened, and the stimulation of small diameter fibers that transmit pain is stopped reflexively. 2. At the supramedullary level, the information received through the large diameter fibers is responsible for the long-lasting production of endorphins with an important analgesic effect. These endorphins would take over from the immediate analgesic effect in the hour following manipulation for several hours. The study by Vernon et al., 1986, shows an increase after vertebral manipulation of plasma beta endorphin levels. This is also confirmed by Sanders et al., 1990, and McPartland et al., 2005. According to Degenhardt et al., 2007, the concentrations of beta endorphins at 30 minutes post-manipulation increased by 11%, while the concentrations of pro-inflammatory 5-hydroxyindoleacetic acid, 5-HT, decreased by 13%. 3. Other effects that have been evidenced are nerve inhibition by stretching the paravertebral nerve according to Main et al., 2003. Change in excitability of neurons. Reduction in pain threshold. According to Picard et al., 2002. There are also mechanical effects that, suppressing the cause of pain, have an antalgic effect. Garcia-Cosamallon et al., 2013. Hiyamu et al. 2013. Decrease intradiscal pressure, and reduction of herniated discs. Release of the synovial meniscus. Increased vascularity and elimination of toxins. Anti-inflammatory effect. Reduction of intraforaminal pressure. Shekel, 1994. Identified 4 effects. Release of the trapped synovial meniscus. Relaxation of hypertonic muscles due to sudden stretching. Rupture of articular or periarticular adhesions. The liberation of the movements of the segments that have suffered a disproportionate displacement. Conclusions in sensitization and osteopathic treatment. Manual therapy inhibits pain and prevents the development of chronic pain by suppressing the temporal sum, a proximal measure of the excitability of the posterior horn of the spinal cord. Spinal manipulation suppresses the excitability of the posterior horn of the spinal cord in a way that can be specific against the development of chronic pain. Manual therapy techniques stimulate many different receptors. Corresponding influences from manipulation may disrupt the nervous system pathways involved in the development of chronic pain. According to George et al., 2006, statistically significant differences were reported in C-fiber fibers that convey pain perception. Temporal sum. After manipulation, manipulation suppresses the temporal sum. Repeated stimulation causes neurotransmitter levels and electrical signals in the brain to change, as neurons develop a memory to respond to these signals. Frequent stimulation results in a stronger brain memory, so that the brain responds more quickly and effectively when it will test the same stimulation. According to Gustin et al., 2012, the somatosensory cortex remodels in response to sensory deprivation, with regions deprived of input invaded by neighboring representations, decreasing brain plasticity and central sensitization. Here you can see a list of all the references used for this presentation. Thank you for listening.